Good afternoon, everybody. Welcome. My name is Suzie Hudson, and I'm the current clinical advisor at the Centre for Alcohol and Other Drugs at New South Wales Ministry of Health, and I'll be your facilitator today. Very excited to be here. You are joining us to check out this National Centre Clinical Research on Emerging Drugs webinar, and I'll tell you a little bit more about that topic in a moment. But I would like to start by acknowledging that wherever you're coming from, and today I'm coming to you from the traditional lands of the Gabaragal people and the unceded lands here, and to really pay my respects to traditional owners, to all of the lands on which you're joining us from today, to really recognise the incredible commitment and contribution of Aboriginal and Torres Strait Islander people to our culture, their connection to country, and to really celebrate the way in which Aboriginal and Torres Strait Islander people have contributed not only to how we understand supporting and healing around alcohol and other drug use, but certainly this continuing culture and this huge place in our country today. We will absolutely today be exploring medication-assisted psychotherapy for methamphetamine use disorder. And joining me today are a wonderful panel of people. We'll start with two presentations, and then we'll be having a beautiful panel discussion. And I think, you know, it's really important for us to be interactive as part of this webinar. You'll find the Q&A function at the bottom of your screen, we hope. And so please do add in questions for our speakers, and then in regard to our panel. You can do that. We'll probably have a bit of a format where we have the two guest speakers today speaking, and then we'll have some time for some Q&A at the conclusion of their presentations, and then they'll join us as part of a broader panel discussion, and you'll have an opportunity to raise your questions of the broader panel. And so speaking today, Dr. Elizabeth Nock and Dr. Brendan Clifford, and they'll be doing their presentations and then joined on the panel by Shawnee Rose and Dr. Jonathan Brett. So I might now hand over to our first speaker. Dr. Elizabeth Nock is a senior clinical psychologist and allied health clinical lead at St Vincent's Hospital, Sydney, Alcohol and Other Drug Service. She was the 2020 NCCRED scholar and investigator and the lead therapist on the SVHA trial. And so now I would like to hand over to Liz to take us through her presentation today. Over to you, Liz.
Thank you, Suzie. Just moving on my screen. Beautiful. You've got my slides?
That's great, Liz. Go ahead.
Thank you. All right, thanks, Suzie. So today I'm going to do a bit of a quick overview of the therapy approaches that are being used within psychedelic-assisted psychotherapy for methamphetamine use disorder, and also run through some of the clinical considerations and therapeutic considerations for this population. So first, a very snappy background to the SVHA trial that provided me with the experience in this fascinating field. To begin with, the search for an effective treatment for methamphetamine use disorder obviously continues. We all know that. And so with psychedelic-assisted psychotherapy, I'm going to call it PAT to save my tongue, showing effective signs in early phase 1 and 2 trials in treatment for depression, alcohol and tobacco use, we set out to complete an open-label, single-arm pilot study looking primarily at the safety and feasibility of implementing a psilocybin-assisted psychotherapy intervention with methamphetamine users. So models of psychedelic therapy that are most commonly used these days in clinical trials have typically come from the psychedelic world over the past decades. So both underground practices and emerging research protocols. They've provided the commonly used framework of set and setting that you might be familiar with, set being the internal state of the person taking the psychedelic, setting being the external environment and sort of safety during the psychedelic experience. And then there's also the model that we followed in SIMAR of preparatory sessions. So we had 3 with a focus on building therapeutic alliance and safety, intention setting, development of skills and understanding for being best prepared for the dose day. And then 1 or more full day of dosing session. We had 1 in SIMAR. And then this is followed immediately by integration sessions, which have a focus on sort of reflection, on the experience, meaning making, and that real sort of future action focused implementation component. So we had 2 integration sessions. So these sessions in SIMAR were always attended by the same dyad of 2 therapists. And so then to this, we add the evidence-based therapy models from the indication that's being studied. So historically, PAT models have used more psychodynamic approaches, thematic-based therapies, often internal family systems. But as we see more and more clinical trials in this space, there's definitely a sense that there's no reason to throw the baby out with the bathwater. And so there's actually quite a good reason perhaps to stick with the therapy models that we know and to adapt them as needed. So of course, within the substance use field and methamphetamine use disorder treatment, we primarily have CBT, mindfulness, and acceptance and commitment therapy, and of course, motivational interviewing. So for SIMAR, we designed our semi-structured therapy framework, which in practice looked like a session checklist around an ACT and an MI approach. So why did we choose these? ACT to begin with, it's really important to note that choosing ACT isn't not choosing CBT. ACT's considered part of the broader CBT family, and they both stem from behavioural psychology, and their behaviour component is pretty similar. And of course, this behaviour component is particularly relevant in substance use treatment, where we're always thinking about addressing addiction as a learned behaviour. But some of ACT's key differences in CBT make it really popular in substance use treatment, and it is used a lot. Really interestingly, though, ACT has a lot of similarities with PAT and the ideas that underlie sort of our understanding of the psilocybin experience. I could spend more time than I have talking through these. I find them really interesting. But this table compares some of the standout shared concepts. So acceptance over avoidance, experiential learning, psychological flexibility, which is essentially the main goal of both. The idea of the observing self, or the self as context, allowing you to notice yourself from new perspectives. Values-based living, sort of as a driver for action and movement towards change. And of course, mindfulness, which is a really key component of both. And while all these are important concepts in all therapy, acceptance stands out for methamphetamine treatment, where regular use can effectively facilitate and reinforce avoidance of feelings and experiences, and also psychological flexibility. Methamphetamine creates neurobiological changes that contribute to rigid thinking, increased impulsive reactivity, and also obviously forms firmly held habitual patterns. Why am I? I think it's a bit of a no-brainer. In my view, motivational interviewing should be a component of all therapy, not just because of its movement towards change, but because of its core person-centered counselling skills, the respect it gives to the individual's experience, and the really nice kind of curious, inviting style of inquiry. All of this, which is a really nice fit within PAT, which centres the patient's experience as a compass for directing sessions. This slide is just a quick reminder that one reason why it might not matter too much what specific therapy is used in PAT is because we know that the modality we use only ever accounts for a small amount of change that we see in any therapy. So this is an image of the common factors approach to therapy, indicating what contributes to change. one of the real strengths of PAT is that the things that we know make the most difference are the therapy non-negotiables in our prep sessions. So while this should be the case for all therapy probably, you simply can't go into an event like a psychedelic dosing day without a strong therapeutic alliance, an established sense of safety, and a process that has genuinely heard the participant and adapted to them. So while we might come with our ACT, MI for methamphetamine use disorder strategies and framework, these are actually only a really small proportion of what needs to be achieved in the prep sessions, at least. Although this might be a little bit different in integration. And the reason for this difference in integration is perhaps motivation. So motivation is obviously a really hot topic in substance use treatment, and it's also really relevant when we're thinking about the mechanisms of change in PAT. There's a suggestion that PAT essentially provides a period of high motivation post-dose. So this might be motivation as its own construct, or perhaps a sudden sort of strong desire for change in methamphetamine use because methamphetamine no longer fits in with the new ideas and changes that are often associated with a positive psychedelic experience. So things like increased connection to the world and others, self-efficacy, a focusing of values. But either way, it suggests that the methamphetamine use disorder specific therapy work really intensifies most in the integration sessions. So it's here that we're going to use all of our known approaches to activating and actioning behaviour change, relapse prevention, that sort of thing. So other considerations. It's been hypothesised that PAT has transdiagnostic treatment potential, which obviously explains why it's being investigated for more and more varied indications. We know that methamphetamine use disorder has a very high rate of comorbid psychiatric presentations, so things like depression, anxiety, trauma, eating disorders, and that these all negatively affect treatment outcomes. But despite this, we don't have any effective treatments that address both methamphetamine use disorder and its common comorbidities. Now, of course, in our day-to-day drug and alcohol clinics, clinicians do their best to start at the beginning, address multiple concerns, but depending on the setting, this is hugely limited by the service model, that sort of requirement to do the AOD bit, the skill and the scope of clinicians, as well as that sort of inevitable struggle of what came first and where we should focus. Whereas PAT, on the other hand, encourages us to really open up and broaden the goals of, or what we call intentions, during prep sessions to anything that feels significant to the client. Sometimes this is related to methamphetamine use, but as therapists, we don't push this idea. And more frequently, the intentions that we found in PSYMA were things like, to understand my behavior better, to feel comfortable in my relationships, to embrace the process. So preparation really reinforces that there's no right or wrong focus for the dose, and participants are really encouraged to hold their intentions loosely and lightly, rather than being focused on having to start by fixing the problem at hand. Now, a really big consideration for PAT when we're treating methamphetamine use disorder that has sort of pragmatic implications, therapeutic implications, and influences study design is the requirement of a number of days of abstinence from methamphetamine prior to psilocybin dosing. So this is something that we include as important to mitigate risks of serotonin toxicity and limit the chance of negative or unhelpful psychedelic experiences that might result from drug interactions or simply from cognitive changes stemming from intoxication or withdrawal. So for PSYMA, we required 2 days of abstinence from methamphetamine and no signs of withdrawal. In Australia, the majority of users of methamphetamine aren't daily users. They're more frequently using on a weekly or a monthly basis. And so for these individuals, remaining abstinent for a number of days at a time is totally possible, meaning that this population does really easily lend itself to PAT. But obviously, daily or almost daily methamphetamine users experience by far the greatest harms. And so leaving this population out of PAP protocols would limit its generalizability from those perhaps with the greatest need. We had a real mix in SIMA. I'm going to go through a case study at the end of a participant that required inpatient withdrawal to achieve a period of abstinence. But for those abstaining in the community, therapists have a really important job of ensuring that the PrEP therapy provided was enough to allow participants to sort of feel confident that they could make it to dose day, having had that break in their use. And so this really practical requirement actually helps anchor some part of the PrEP sessions in real collaborative conversation about how methamphetamine use fits into an individual's life, their triggers, patterns, and behavioural planning. And I mean, this is interesting because actually the focus of PrEP sessions might not include much of that work if it wasn't for this need to sort of pretty quickly together achieve this period of abstinence. Now, just some extra considerations that are specific to methamphetamine treatment. Obviously, the risk of psychosis, which is prevalent in methamphetamine using populations, is a major exclusion criteria for PAP trials. But if this treatment appears or is found to be effective, we're not there yet, research will really need to work harder to better understand safety profiles. Because what we're really looking for are effective treatments that can be offered to the most people. There's also a suggestion from previous research that frequent methamphetamine use might lead to a reduced psychedelic effect, and that psychedelic effect is thought to be associated with outcomes. But we didn't find this in SIMA, which is positive. And of course, lastly, the much talked about challenge of designing placebo-controlled trials in psychedelic-assisted psychotherapy. One could argue this is possibly an even bigger issue within a population that are very familiar with the effects of substances. Okay, I'm going to jump into a case study that details one participant's SIMA journey. This has been written up as a paper, so you can read it in more detail. Now, so PM is a 36-year-old trans woman. She's employed in the arts sector, and she'd begun sex work 6 months prior to coming into the study. She was in a relationship with a man who was also methamphetamine dependent, and she'd been diagnosed with ADHD at 35, but this was unmedicated due to her methamphetamine use. She described a pretty happy childhood, loving supporting parents and siblings, but mental health difficulties that began in adolescence associated with gender identity issues. So PM's methamphetamine use, she'd first used 2 years prior to study enrolment, initially in the context of recreational sexual activity. But this has pretty quickly progressed to daily use over the following year, and the context had also expanded beyond sexual activity. So when we met her at screening, she reported methamphetamine use 27 out of the previous 28 days, and she was smoking about half a gram a day. The withdrawal symptoms that she could describe were sort of a standard 2 to 3 days of extreme lethargy, followed by intense craving. So PM reported quite a lot of concerns around her methamphetamine use. She experienced constant exhaustion and fatigue, if not using, difficulty forming and maintaining friendships with those not using methamphetamine. She was aware that she was increasingly using more and for longer than she intended to. She was really frustrated by, I guess, the time waste taken up by meaningless activities she called cractivities. She was aware that the adverse effects of methamphetamine were actually sort of stopping her from achieving life goals and were impacting her career negatively. Overall, PM presented as a really intelligent and articulate person who was frustrated with the way that methamphetamine was interfering with her ability to think. So her period on the trial was quite interesting. She completed her first 2 PrEP sessions spread over a 5-day period in the community. But immediately after that second session, she was admitted for a planned inpatient withdrawal. During that time, she received sort of symptom relief, low-dose diazepam for the first 2 to 3 days, and then no pharmacotherapy in the final 48 hours. On day 4 of her inpatient stay, she completed her 3rd PrEP session, and on day 5 of the inpatient stay, she was discharged to the dosing session and where she received her dose of psilocybin. Throughout that dose day, vital signs remain normal, and we can see from her scores on the mystical experience scale that she indicated she had what we would call a complete mystical experience, so I guess quite an acute effect, and also scored high scores on the emotional breakthrough index. So after the dose day, PM described seeing her life in great distance and perspective. She had feelings of interconnectedness of events and interconnectedness of relationships, as well as methamphetamine use and her professional pursuits. Interestingly, she described a series of insights that continued to follow immediately after dose day that had positive impacts. And she was aware of a capacity to make changes swiftly. So she was really able to move fast, as well as a new sense of equanimity. She described positive increases in distress tolerance and her ability to observe difficult experiences and sensations without needing to avoid them. And she really got sort of actively doing things differently. She engaged in planning alternate activities to enhance her sober experiences. PM had no adverse events from her time on the trial. Really interestingly, although her initial goal had been to reduce her methamphetamine use, this shifted to complete abstinence following her time on her intervention in the trial. She was abstinent from methamphetamine use at all follow-up visits, which was up to 3 months post-dose. This is recorded via self-report and urine drug screening. And you can see there that her cravings, while 100 out of 100 at baseline, so very high, dropped significantly at follow-up 28, with a slight increase at the 90-day follow-up. She attributed this increase to stress relating to breaking up with her partner in the 3 months post-dose, but she found herself able to manage these stressful life experiences without returning to methamphetamine use, which was different to her previous experiences. So what does this case, I guess, show us? It demonstrates one single case in which the participant described a number of positive effects and changes following the trial intervention. It demonstrates the use of inpatient withdrawal to enable a participant with daily dependent methamphetamine use to be able to participate safely in a trial of PAT. I guess it makes us think that if PAT was found to be effective as a treatment for methamphetamine use disorder, further consideration of models that allowed inpatient withdrawal to occur prior to the dosing intervention would be really important for expanding the generalizability and accessibility to those that are often needing the treatment the most. And there's the paper if you'd like to have a look at it.
Thank you so much, Liz. That is fascinating and just really exciting to see a fantastic response and to explore that case study. There's one question that's come through, and please do pop your questions through for Liz. You'll have opportunity as part of the panel as well, but please pop through your questions. So the question is what the reasoning behind that 2-day abstinence period being required before dosing. Can you just, you explain a little bit about that?
Yeah.
Expand on that a little bit.
Look, I might let sort of John Brett speak a bit more to the the potential sort of serotonin toxicity and the sort of, I guess, the things we probably don't know so much about but are cautioning against around potential drug interactions. But I mean, there's obviously some quite practical components to that as well, in terms of being in the best sort of cognitive state that one can be in for PrEP 3, which occurs the day before the dose day. So with that kind of real good chance to check in on how things actually are in terms of that mindset and progressing to where we'd want them to be for a safe dose day. there's that sort of cognitive aspect, and there's also, you know, the conversations that we have in prep about, you know, if withdrawal really does look like a significant crash, that's something we're going to need to consider as well. And we actually
Yes.
even attempted to extend that beyond 2 days to sort of really allow for prep 3 and the dose day to be someone, you know, as ready as they can be and in the best frame of mind for that day.
Yeah, I mean, I think it's also really interesting to think about all these different components. You talked before about that preparation, that therapeutic alliance, and how that can really support this process. So all these things are working together, aren't they? I think sometimes we can focus on only the drug itself, but really we're talking about all these different things that are coming together and being harnessed. There's another couple of questions here, and John and Brendan and Shawnee, you know, feel free to jump in as well. So the question here is there consensus on how many days from being free from SSRIs or SNRIs are required prior to dosing? And this might be a good one for John, perhaps. But perhaps I'll hand it over to you, Liz. Would you like to answer that, Liz, or would you like me to hand it on to John? What would be your preference?
I think John can probably answer that one better.
Yeah, thanks, Suzie. What a good segue. So we're actually doing a study at the moment looking at keeping people on their antidepressants and dosing psilocybin on top. However, most of the other studies that have looked at treating treatment-resistant depression with psilocybin psychotherapy have required people to be off their antidepressants for at least a month. So some studies have withdrawn people from their antidepressants quicker than others. I think there's good evidence to say now that there's, you know, it sort of varies depending on which antidepressant you're on, but you know, with SNRIs probably being more severe withdrawal syndrome, but there is a recognized withdrawal syndrome for antidepressants. So essentially, the slower you can do it, the better. You know, I think current guidelines kind of recommend over about 4 to 6 months, actually. So other studies, like there's a big Carhart-Harris study, which was a randomized controlled trial, which found that taking people off their antidepressants, and they did it sort of fairly rapidly, can be an effect modifier for the antidepressant effect as well. So, you know, essentially, if you're sort of still in withdrawal from your antidepressant, you might not have as good a response to the treatment, the psilocybin treatment anyway. So I think the guidance is, while the jury's still out on whether you can still dose on top, slower is always better.
Thanks, John. That's very helpful. There's a couple of other questions coming in, but I just want to keep us on track in terms of time. Some of them relate specifically to the availability of this treatment, but I think it's safe to say that currently what we're talking about here is treatment that's been provided within the context of trials and gone through an ethical process and having to be involved in a trial condition. There are private, currently, as I understand, privately available clinics, and perhaps we could talk about that as part of the panel discussion, because I think that's a really useful one for people who've tuned in today. And then there's some questions about involvement in child rearing or child care. Perhaps, Liz, can I just ask you, were there any people involved in the CIMA trial that had the care responsibilities of children at all, or was that part of a criteria that people weren't involved in?
That's a good question. I think probably 1 or 2 of our 15 had children. They weren't the sole carer for those children. And I think really the consideration is there. There's no suggestion that returning home, should, negatively impact or, in any way sort of impact functionality. But we do, for lots of good reasons, put in this requirement that the night of the dose, the participant is in a safe environment and in the presence of a supportive contact, friend, family member. And so that's very much sort of a precaution, obviously, to ensure that sort of for that brief period after being deemed sort of safe, that the dose is worn off, from our research rooms, that's there as a safety mechanism. However, people absolutely return to their jobs the next day, for example. Again, maybe not, it'd be nice to have a day off after it, but it was it was doable for some people. Yeah.
Yeah, thanks, Liz. That's very helpful. And then just one final one for you, Liz, because I think it's quite relevant. That aftercare. So obviously, the person who's involved in a trial like this, are you, once that period of the dosing and then the integration has occurred, are you then providing that transition back into some counselling support? Is that usually what's been set up prior to their involvement in the trial? Can you just respond to that one, please?
Yes, that's really important. And I think that's probably a factor that trials in future will look more and more at, how we do get that integration or continuing integration piece right. But for us, we actually had a requirement that participants coming onto the trial already had a good relationship with some form of sort of supportive counselling therapist. If they didn't already have a relationship like that, we did link them in with our clinic at St Vincent's, so that there was, and that was in advance, so there was sort of a support network already set up. Our 2 integration sessions, did actually feel obviously very brief, but maybe also enough. And so we would do, where possible, sort of somewhat of a handover, obviously handing over some fairly big ideas at times,
Yes, sure.
to the treating clinicians that care continued on with afterwards.
Excellent. Okay, then there's quite a few questions that we will, I think, we'll turn to after Brendan's presentation, because I think they'll be relevant to both, which is about some other medications and ongoing follow-up and support. So at this moment in time, I'd like to introduce Dr. Brendan Clifford. He's a senior research fellow with the National Centre for Clinical Research in Emerging Drugs. He's a clinical researcher who uses interdisciplinary methods to further health equity and enhance access to evidence-based healthcare. He's worked broadly in clinical background in Ireland, in the UK, in Australia, mainly emergency department settings, and is also undertaking clinical research in alcohol and other drugs. He's held lots of roles in health innovation and lectured in public health and social science, and has completed his PhD examining intersectoral policy for homelessness and health at the Mackenzie Centre for Health Policy and Economics. And I would like to hand over to Dr. Brendan Clifford, who will be talking us through ketamine-assisted psychotherapy for methamphetamine use disorder. Over to you, Brendan.
Thanks, Suzie. Hopefully everybody can see my screen. And thanks, Liz. It's a great advantage having you go first, so that you've set the scene very nicely, but I also have the disadvantage of talking about work that's yet to be done, whereas you've given some very interesting studies of stuff that you've already done. What I'm talking about today is a study that we're about to commence. So it's a protocol for a pilot of ketamine-assisted psychotherapy for methamphetamine use disorders. You can see there that I'm just part of a very big team who's contributed to the design and the operations of this, including our clinical trial staff here at St. Vincent's. So ketamine is, I talk about medication-assisted psychotherapy. Ketamine is not a classic psychedelic. It works in a different set of receptors. So it was synthesized in the 1960s. It's a derivative of PCP. It works primarily on the NMDA receptor, and it's got very well-established use as an anesthetic in human and animal medicine, because it doesn't have the disadvantage of respiratory depression that other anesthetics have. I'm not going to explain all of that stuff that's happening in that image, but you can see there that there's a few, it works kind of differently to the top, which looks at psilocybin and expectant serotonin, and ketamine has a different set of receptors that it's working with. Ketamine is also used for pain management quite extensively, and I think even just this week, the PBS has started funding S-ketamine for depression, and that's well established. And there's increasing evidence, S-ketamine is administered as a nasal spray, and there's increasing evidence that subcutaneous ketamine can actually work quite well for that cohort as well. For ketamine-assisted psychotherapy, here's just a slide of a narrative review of the literature around where ketamine-assisted psychotherapy is being applied. So you can see it's being very much applied in the mental health space, a little bit in the chronic pain space, and that there's emerging kind of studies looking at ketamine-assisted psychotherapy in alcohol, cocaine, and for opioids. Nothing yet for methamphetamine, so that's where we're focusing our study on, is that first kind of look at what ketamine-assisted psychotherapy might look like in this space. There's a few potential mechanisms of how ketamine might work for a substance use disorder. And there's 6 kind of here. There's the first one is looking at neuroplasticity. So ketamine has been shown to form new to promote neuroplasticity in the brain, so the formation of new synapses between neurons, so synaptogenesis, as well as new neurons themselves, so neurogenesis. The second one, functional network disruption, just talks about how the connectivity between different parts of the communication network of the brain can be disrupted. So the exact mechanisms of that are not clear yet, but there's interesting MRI or fMRI studies of LSD and psilocybin for that mechanism, and ketamine could have a similar effect through elevated levels of extracellular glutamate. It's also, ketamine is known for this, it can have quite rapid antidepressant effects when it's administered. And if that can treat comorbid depression in people with a substance use disorder, that could facilitate better response to engagement and the effect of psychotherapies and other treatments. Memory reconsolidation is another putative mechanism, which very much at the preclinical study stage, which looks at how ketamine could disrupt drug-related reward memories. Again, that's quite preliminary. There are I don't need to talk too much about this, but the mystical and psychedelic effects. So it does work as a dissociative, and people can gain insights, feelings of resolution, catharsis, spiritual meaning making, and changes in self concept associated with that. And that again might link back to that functional network disruption that we spoke about with that earlier mechanism. And then finally, and kind of what we're basing our logic model really is on how it can enhance psychotherapy. So the uptake of psychological therapy could be facilitated after ketamine because of that synaptogenesis and that neurogenesis. And so you get improved learning of relapse reducing strategies, such as you would get with CBT. And so that's kind of what we're looking at here, is how does it work? How might it work that way? So the intervention that we've kind of landed on is this, it's quite closely connected to the 4-session CBT intervention developed by Baker that we've used to work with people in clinical trials. It's quite an accessible one for counseling staff to work with. And what we've done is we've kind of stayed close to the evidence with our CBT and then added in our ketamine on top of that. So it really is, this is a CBT intervention with ketamine to just give it a boost. The kind of, we're using subcutaneous sub-anesthetic doses of ketamine, which gives you the advantage of less monitoring needed than for intravenous administration. And there's the literature suggests there's a 24 to 48 hour window of increased neurological potential. So we've scheduled our CBT sessions to occur within that window. We haven't looked or designed our study to work with the dissociative or the psychedelic effects in particular, as some models of the medication-assisted psychotherapy, but they might occur, and we want to see if they could be useful. So we're using that to support it. So we will have at the beginning of, we will have some preparation kind of following the psychedelic model, which people will require anyway. This is kind of a novel way of engaging people in treatment. And then we will have, prior to each CBT session, there'll be some integration of any insights that may have occurred during the ketamine session. The ketamine session itself is the injection followed by 2 hours of close observation by nursing staff to make sure that people are okay. The study itself, I haven't made a QR code. The study itself, but you can look at the other details on the protocol paper that I flashed up at the start. We're looking at feasibility, so time to recruit, retention, completion. It's the first time we've tried something like this, as well as safety. So getting that really fundamental data about, with this new population, what were the things that we might need to look at. So just general adverse events, making sure blood pressure is okay, mental health, sequelae, and non-medical use liability as well. Looking at, we've also got those exploratory measures to kind of figure out what would the what would be the measures by which we could understand if this would work for people. So methamphetamine use in terms of days, craving, withdrawal, looking at whether the dissociation is important, whether the mystical effects are something that actually happen and valued, the effect on quality of life measures, including depression, anxiety, sleep, the other HIV and other STI risk behaviors, and neurocognition as well. We want to look at acceptability quite closely, and that's with a couple of tools, looking at the medication and the psychotherapy component. But really importantly, and to me this will be the one of the important pillars of the study, is looking qualitatively. We will interview all of the participants to figure out what was important for them, what was meaningful for them, and what might be important to enhance for later versions of this intervention, or later studies of this intervention. That's all I want to go through, because I'm quite looking forward to the discussion. I haven't got a QR code there either, but if you just go to the NCCRED website, on the landing page, you will see the details for the study itself if you want to know more.
Thank you so much, Brendan. That's brilliant and really exciting, I suppose. And so people who would like to get involved, they can go to the NCCRED website. In terms of recruitment, is that open now?
Yes, we're currently recruiting in Sydney. You do need to be able to come to the hospital at St. Vincent's, and that website will bring you through to a questionnaire as well for people that are interested or potentially interested in enrolling in the study.
Brilliant. And just, in relation to some of the questions that were asked that we haven't directly answered, obviously for some people, will then also in this trial need to be a 2-day abstinence period prior to the ketamine being administered, or not?
No, because we're giving a kind of like a comparatively low dose of ketamine compared to anesthetic levels of it, so we're a bit more comfortable with people with people's methamphetamine use prior. We do think it's really important that people just have a really good night's rest, and that's often the biggest thing about methamphetamine use. Is like, you need to have a good rest. You're going to be lying still in a room for a couple of hours, so
Yes.
like having a good rest sets you up the best for your brain to make the best advantage of whatever boost you might be getting from the ketamine. So we really think that that's just an important thing to do, as well as just actually facilitates you getting to the clinic on time for when all of the nurses are ready and when all of the pharmacists have, there's a bit of work that goes into actually just orchestrating the administration of the drug as well. So actually arriving on time. So there's lots of just practical reasons to avoid that, to set yourself up for the best experience that you can have that day.
And just 2 more questions for you. One is it possible to use S-ketamine rather than SC-ketamine?
So S-ketamine we looked at that, and really it doesn't give you any advantages that we can find over subcutaneous ketamine. Subcutaneous ketamine is also it's more reliable in terms of its administration. There's quite a lot of technique to actually spray nasally. You actually, and it's a few sprays you need to do with an S-ketamine spray. It's not just one and done. You actually need to get a few in there, and they all need to be correct. And actually, then it's how it's absorbed is quite variable. So the absorption is more reliable if you give it as a subcutaneous injection. There's no difference really between a subcutaneous injection and intramuscular injection. So the subcutaneous is a bit more comfortable than other routes of administration. And then also just in terms of scalability, ketamine for injection is just really, really available and just very cheap as well. So it just makes a really scalable intervention, which is another advantage for it.
Excellent. Thank you so much, Brendan. I might now invite everybody to come onto our panel. And so joining Brendan and Liz will be Shawnee Rose. They are a dedicated harm reductionist and advocate, identifying as both a peer and a professional in the AOD sector with strong emphasis on integrating lived experience into their work. Currently, Shawnee works as the Health Education Officer at the Medically Supervised Injecting Centre, where they're an active member of the Health Promotion Team and the Consumer Action Group. They've also also been involved in some amazing other organisations such as NUAA, KRC, Unharm, and really contributed to the New South Wales Drug Summit more recently. Shawnee was an associate investigator and provided consultation for the grant application and pilot project focused on psilocybin-assisted psychotherapy that Liz spoke about, and they hold a diploma of counselling and continue to pursue professional development through ongoing education. I'd also like to welcome Shawnee onto the panel. And Dr. Jonathan Brett is a Senior Staff Specialist in Clinical Toxicology and Addiction Medicine at St Vincent's Hospital, Sydney, and the Clinical Director of the Psychiatry and Non-Prescription Drug and Alcohol Unit at St Vincent's. He's a toxicologist with the New South Wales Poisons Information Centre and holds fellowships in Clinical Pharmacology, Toxicology and Addiction Medicine, Conjoint Professor at UNSW and Senior NHMRC Research Fellow with the Centre for Big Data Research in Health, and a Chief Investigator, should I say, for a pilot study on psilocybin-assisted psychotherapy for methamphetamine addiction, and is leading the psilocybin trial for treatment-resistant depression at the moment. So what I'd like to do is welcome you, John, to this panel as well. And we've got some fantastic questions that people are coming through with, so please keep them coming. I think one of the key things people are curious about is availability of these treatments. Obviously, we've been talking about 2 trials here. And I suppose I'd like to bring you in first here, Shawnee, because obviously I think at the moment what we know, particularly in New South Wales, is that those programs that are outside of a trial environment are quite expensive. And obviously one of the things we're talking about here is a potential population group that might not have the same opportunities as others to access the treatment. So I wanted to bring you in here at this point about availability and acceptability of these kinds of new treatments and what your thoughts are about what we might need to do to make it a little bit more accessible.
Yeah, I think this is the really hard part. Having these kinds of private sessions using psilocybin to treat, substance use disorders or, mental health disorders as well is incredibly costly. It's really expensive, and then that means that most vulnerable populations of people who need this treatment the most are the people who are able to access it. I guess this is why hopefully these trials are taking place, so maybe we can hopefully get them to broader communities who aren't as wealthy, who can't afford the really expensive private treatments. And yeah, I mean, plant medicines to treat mental health or substance use disorders, I guess, have been around for a millennia. It's just been in the underground. It's about bringing them to the surface so we can look after people in the process.
Absolutely. I think you're exactly right. How do we bring some of these things, all the pieces together, I suppose? Does anyone else on the panel have any comments about that accessibility side of things? Do we know enough? Yeah, John, go ahead, please.
Yeah, so I mean, people might be aware that you can now access psilocybin and MDMA through an authorised prescriber scheme through the TJ rescheduling last year. But I totally agree with Shawnee. The issue there is it's for a very narrow indication. So treatment-resistant depression for psilocybin and PTSD for MDMA. But also, it's not publicly funded. So currently, it costs about $20,000-$30,000 per treatment. So it introduces a really big health equity issue. Obviously, the people who probably need the treatment the most are the ones that are least likely to afford it. So here we need to try and do the work necessary for registration and funding by the PBS. The risk also always is creating an alternative pathway to registration, like happened with medicinal cannabis, which means that it'll never be funded. And they also the risk is, as evidence emerges, that people just try it at home, and there's various kind of things, ways that looks like. One is just getting psilocybin and taking it yourself at home. The other is going to a sort of underground practitioner. And there's a range of risk involved with that. And we did a recent study of naturalistic experiences showing that you're not guaranteed a good outcome. In fact, about a third of people had a negative outcome in respect to their sort of drug use and mental health. if using methamphetamine and psychedelics together. So
right.
yeah.
And so, I mean, but you, through your experience, Liz, obviously you talked a lot about, that therapeutic alliance, the preparation sessions. In the case of the CYMA trial, an 8-hour period of dosing, sitting there with that person. So there's obviously some implications for the need to have those additional parts of the service, if you like, or the treatment. Can you tell us a little bit about why you feel that's been quite an important part of it, and I suppose speak to John's point about if you're just taking the drug in and of itself but without these other supports, what do you think about that? What do you think about that?
Oh gosh, that's potentially a big answer. Yeah, look, I mean, I think first off, to your point, sort of around the therapy that wraps around the dosing, this is very much a model that is being, it's only being considered as psychedelic-assisted psychotherapy. Of course, there is a huge amount to understand further about the components of that, that assistance and the therapy component that I guess are most useful, most important, most essential. At the moment we do things like run, trials with two therapists, for example, and that's somewhat of a safety mechanism. Simply practical reasons like someone being in the room with the participant for the full dose. Is the two therapists necessary? Maybe not, but we obviously start with we start on the cautious side and we move in our research sort of to look at, the more we know about what are the sort of the key bits that we can't do without. And we're still very much in the really early stages of that. And I think I just would like to point, out to another part of this question that, while the TGA rescheduling has occurred for treatment-resistant depression with psilocybin, and is not yet accessible, in any way financially to most people, that rescheduling is very much not for psilocybin for substance use at this stage. And the research that we're doing is the really early stage. I could have sort of done a whole presentation, obviously, on sort of the background to our trial, where we really reinforce this. We were looking at safety and feasibility.
Yeah.
We're not really particularly close to having much understanding of the effectiveness yet. And then, of course, there's all those next stages, which I did mention around the risk profiles, which is so important if it does, prove effective, because we do want to expand. We want to deliver a model of effective treatments that are, not only useful for a small portion of the population, but there's so much more that we need to understand about what those risk profiles look like. And that's everything from which parts of the therapy bit is key, and which parts are maybe not so key, and which parts of the safety, the safety requirements are key.
Yeah, and I suppose it also talks to that experience of, say, polydrug use. And there's a couple of questions, and comments in the chat about, opioid agonist treatment, perhaps that people might be on, or perhaps if people are using other medications or other substances. Can anyone, or does anyone like to sort of comment on that? I mean, in your trial, Brendan, will people be able to be using other kinds of substances and still be eligible, for example?
Yes. So if like increasingly overseas, for instance, if you have a stimulant use disorder, you're likely to have an opioid use disorder as well. So we've tried to, at this point, be as inclusive as possible to get, and it's always a tension when you're designing stuff, as inclusive as possible so that you've got good generalizability, as much generalizability, but also a sample that doesn't confuse signals of efficacy or signals of safety by an actual adverse event being caused by something else. So it's always a balancing act, and there's always a judgment about how you protocolize inclusivity with the clarity of safety signals. For us, for the CAPA study, people on stable opioid use treatment, opioid use disorder treatment, are welcome onto the trial. There are some specific criteria about how stable your OAT needs to be included. Certainly, I think that's an important at this stage to kind of to be as inclusive as possible for people to come onto the study. And then other things, With other substances, it really is looking at moderate to severe, and mild would probably be okay for a lot of things. But it really depends on, and so it really depends on the criteria that we use to assess these disorders.
And just quickly, Brendan, can you just run us through the dosing? Do you know what the dosage schedule is yet? Can you just run that through?
Oh, yeah. So it is that 0.75 to 0.9 milligrams per kilogram. It's staged up, so we try to get it to as high as possible. We start off low, and then you can vary it on the second and third doses depending on responses. I think it's all a question too about how it's given. So you do just give a subcut injection as one bolus dose. It's not an infusion over a certain amount of time like you would have with an intravenous infusion. So it's just given as a bolus dose and then wait for a couple of hours.
Okay, thank you for that. And then just in the essence of time, one question from around selection bias. Obviously, do we feel like, in terms of, obviously, when we're choosing to trials, you have to think about safety, you have to think, often that can be, might not mirror, daily life situations. Perhaps you could just briefly comment on how you see the generalizability. I mean, I suppose what both studies are looking at are much more about safety and efficacy. Safety and feasibility rather than efficacy. But any comments on the generalizability given who you see come through the door? Brendan, perhaps you first, yeah.
To me, this is a great question because that really depends on our community being activated to engage in clinical trials. So that's people in the community being literate about what clinical trials are for. So they're about their experiments to see participating in science, and they are burdensome. But they do contribute to the science for the community. So it's a really good contribution to your community if you participate in a clinical trial. And also our clinical sites, like the more clinical sites we have engaged in drug and alcohol research, the better our science will be, because it means that we've got a broad section. Our sample of who we work with here in Sydney is quite different to the sample we work with in Newcastle. And so the more clinical sites we have online, the more people we have stepping up to engage in research, the better.
And on that point, Shawnee, have you got any thoughts about, what is the role for peers and supports to sort of help facilitate, people through these kinds of trials? Because you're exactly right, and Brendan and yourself, Liz, you mentioned, there are these perhaps expectations. It's quite burdensome in terms of what the requirements are. Shawnee, do you feel like there's a bit of a role there for trying to help break down some of that, or
Oh yeah, absolutely. I think that's where your integration comes in, and I think moving forward with future studies, I hope that integration is one of the practices that doesn't do away with, because I think that's how you maintain the lasting effects of your treatment, and how you can take them into your everyday life. Doing something that reminds you of, an epiphany that you had during your treatment, and then engaging in that practice daily so you can bring those lessons learned with you into each day is super important. And I think that's the space where peers should be involved. Yeah.
Fantastic. Yeah, and I think we're all hoping that, exactly as you've just mentioned there, Shawnee, that this can be something that's sustained, that's something that starts within the context of these trials, but how does it get sustained beyond the dose day or the integration day? And just for the group, I suppose, in terms of what your sort of hopes are for next steps, perhaps if I could just ask each of you, I mean, Shawnee, you've indicated, that the peers are a lot more involved, particularly in that integration part. But there are other things that people on the panel just wanted to briefly mention about what their hopes are for this kind of work. John, perhaps you could kick us off.
Yeah, thanks. I mean, I think, we started this all 5 years ago from nothing. And so now we have, a group of about 12 trained therapists. We've got a very active research program. We've got enormous capacity, and we're, kind of leaders in the country in some ways of investigating this for these modalities for mental health and addiction. So I think I'm so pleased about where we've come from, and a lot of support from NCCRED as well, with our psilocybin work. So I think the next steps for methamphetamine with psilocybin is two things. One is to address the generalizability, like you sort of mentioned, which is, can we what groups can we expand this to? You know, is it safe to dose people with a history of stimulant psychosis, and you know, what parameters could we put around that potentially? Another is sort of cost effectiveness and addressing people out and costs. So, you know, there's some evidence that group work might be equally as effective, if not maybe more, in encouraging communities and you know, peer support. So, you know, investigating that as a potential model. But I think ultimately, you know, upscaling to a larger trial that's actually powered to show effectiveness across multiple sites. And that's what I've been flogging myself writing grants for. So
sounds good.
Hopefully that gets across. Yeah.
Look, I'm very mindful of the time, and I don't want to cut anyone off because this is a fabulous and rich discussion. But I suppose I just wanted to add to anyone on the line, please reach out to Brendan, Liz, John, or Shawnee. We will absolutely try to answer your questions that you put into the chat about some of the specifics. But we really thank you for joining us today. It's been a wonderful discussion, and we want to keep it going. So please do reach out to everybody. There's more information on the NCCRED site about all of these trials, the papers that have been produced, and so check that out, and we'll respond to the questions as well if we can after this presentation. But thanks so much for joining us. Thank you, Shawnee. Thanks, Brendan and Liz and Jonathan. Thanks to the NCCRED team, and we hope to see you at the next webinar. See you later.